Two, one, we are live.
Good evening, everybody. Welcome to the fifth session of Listen to the Legends, presented by West Bengal Academy of Pediatrics. This is a very flagship program of West Bengal Academy of Pediatrics, and we are delighted to have today's speaker, none other than Dr. Anurag Bajpai. He will be speaking on technological innovations in pediatric endocrinology. And moderator will be Dr. Sumana Kundogrami. Sumana is our active member. She is the Associate Professor of Pediatrics, KPC Medical College and Hospital. She is MD in Pediatrics, MRCPCH, and she has got fellowship from SAR only, Dr. Bajpai only. So before handing over to Sumana, I'll request our Secretary, Dr. Mihir Sarkar, to welcome all the delegates and the speaker also. So over to you, Mihir.
Thank you, Shapanda. So it is my privilege to welcome you all for this fifth session of meeting the legends of West Bengal IAP. So we had a previous fourth session was a very helpful and a very interactive, and the legends from the different parts of the India has joined, and they get their wisdom and experience, shared their experience with us. So in this fifth session, I welcome you that I can see that our national EPs have joined, and all the from the various parts of the country. Dr. Nandis, Dr. Devendra, Dr. Amal Pawar, Dr. Singara Bellu has also joined, and also along with our IEP West Bengal members. So I think it will be going to be a very great session, and sir does not require any introduction, Dr. Anurag Bajpai sir, though Dr. Sumana Kuntakami will formally introduce sir, but he's the legendary figure in the pediatric endocrinology all over the India. Has started the pediatric endocrinology actually, who have from and popularized it and started the fellowship. So this is going on to and the percolating across the country. Over to you, Dr. Sumana, to introduce sir formally and start the session.
Thank you very much. Good evening, everyone. It is my absolute pleasure and honor to be the moderator in today's session of this wonderful initiative called Listen to the Legends. I'm thankful to West Bengal Academy of Pediatrics, Shapon Roy sir, Shukanta Chatterjee sir, Kripashendu sir, Mihir, and everybody, all the dignitaries for giving me this wonderful opportunity. Sir is my guru, mentor, and guide, and so it's extremely exciting. It's an extremely exciting moment for me to be able to introduce him. What can I say about him? Sir is the current president of ISPE, and sir is the director of MediClasses, a wonderful learning portal. Sir is the author of multiple pediatric endocrinology books, and which we read every day. He's the key contributor to different national, international protocols and guidelines of pediatric endocrinology. But I think his main chief contribution, pioneering work will be in creating this wonderful learning portal called MediClasses. The learning portal, the app, and his legacy will be there in the students that he has created, the adult learners, pediatricians all over the country and the world, and here and there. And of course, he's an inspiring teacher. The way he teaches, he makes endocrinology sound and look so easy for us with all his algorithms and approaches, and he has this aura of his own. So, and of course, the topic that he has chosen today, technological innovations in pediatric endocrinology, what a relevant topic. And of course, we are at that time, that intersection where, these technological innovations are actually reshaping the landscape of pediatric endocrinology, be it CGMs, be it the smart insulin pens, be it AI, helping in the early diagnosis of different diseases, to maybe the telemedicine apps. So AI, the whole technology is actually reshaping the landscape in front of our eyes. So thank you, sir, for choosing such a topic. We are looking forward to a very enlightening session from you. Thank you so much for being here today. Over to you, sir.
Just before sir starts, we have got Dr. Atanu Bhadra, the Central IP Treasurer. So Atanu, just a line and welcome Dr. Anurag Bajpai, sir.
Yeah, I think uh, we have already on the link Dr. Nandish sir, our National Action Plan Coordinator, along with the
Namaste, sir.
Kamal Power, Dr. Devendra Sarin, present DB, Professor Kaustav Naik, Dr. Rajshekhar Rai, and we have Dr. Kasi Bandaru from Andhra Pradesh. So I think we should not waste time. Let us start the academic program. Then at the end we can take a comment. We also have Dr. M. Singarevelu sir, who has joined in, and many people will join in, and at the end we will take the questions, sir. So Dr. Anurag sir, we are very eager to listen from you.
So,
Thanks
sir,
a lot, Dr. Yeah,
please, sir. Please
yeah.
continue.
Thanks a
I'm
lot,
just
Dr.
telling to the
Atanu. Yeah.
This, Aditya, mute all except Dr. Sumana Kundograni and Anurag Bajpai, sir. Mute myself also.
Thanks a lot, the entire team of West Bengal IAP, including Dr. Atanu, Dr. Swapan Rai, Dr. Sumana, and the entire team who has invited me for and given me this opportunity to interact on one topic which is very close to my heart. And why it has been close to my heart? Because we know that pediatric endocrinology represents one specialty in pediatrics, which really has a lot of implications, but unfortunately, its management has been quite challenging. I hope the slides are visible now. So the major challenge, yeah, most people think that pediatric endocrinology disorders are rare. They are very, very complicated. They require a lot of workup, which is very, very expensive, and the treatment is very exorbitant. Now, because of all these misconceptions, there is often a process in which the disorders are often not diagnosed at the right time. And when they are diagnosed, the management is inappropriate. What I'll try to showcase over the next 30, 45 minutes or so is to see that most of the pediatric endocrine disorders are actually mathematical in terms of analysis. And if we are able to apply our algorithms correctly, we can use minimal resources and investigations to reach the correct diagnosis and can have a clear outcome in that regards. This whole process has started approximately now 17 years ago when I had come back from Royal Children's Hospital, Melbourne to Kanpur. At that point of time, I was really shocked to see this case. I always mention this case because this reminds a stark reminder. This was a 17-year-old boy at that time who had come to me with growth failure. His height was only 140. He was very short. He had fused epiphysis. Now, this is something which is not unusual in our clinical practice because still we are seeing 15 to 20% children who come to us with short stature come at a late stage in terms of growth. What was shocking in this case was that he had presented to a doctor at the age of 10 years with anemia, for which blood transfusion was given. Now, this child was a walking case of celiac disease. He had all the features. He had pica, he had clubbing, he had anemia. And at that point of time, had a TTG been done, we could have avoided this blood transfusion. And tragically, this blood transfusion had resulted into HIV/AIDS. So this is how a simple disease which could have been identified with lesser resources. The cost of TTG would be around 1/10 the cost of blood transfusion. That was 17 years ago, and then the awareness has increased. But this was really shocking as to how things came to this end, and we could have avoided that from that perspective. So this was clearly an issue of late presentation on the part of the parents because of the patient awareness. And finally, the physicians were also not aware in terms of what would be the appropriate investigation or workup in that regards. Now, whenever we talk about any particular condition, the key questions which are often asked is why are these problems happening? And people talk about 3 A's: awareness, accessibility, and affordability. And a lot of people in endocrinology particularly talk about, okay, the accessibility is not there. There are not many pediatric endocrinologists around, and the cost of investigations are very high, so they are not affordable. But the real matter is that the most important factor here is awareness, to know when to evaluate, to know how to evaluate. And this awareness is not only at the level of the patients, it's also at the level of the clinicians, which needs to be there. Now, this, of course, is something which we are really worried about, that the number of pediatric endocrinologists in India is limited. This number, thankfully, is gaining ground with the development of fellowship programs by ISPE, by the DM programs, but still the numbers are quite low compared to the overall pediatric endocrinology burden. So it's impossible for these 100 to 200 pediatric endocrinologists to cater to everybody. What we need to do is to build a bridge between pediatricians, pediatric endocrinologists, and people who have special interest in pediatric endocrinology if we really want to expand pediatric endocrinology reach across the country. And this is what I've been trying over the last 15 to 20 years or so. Now, coming back to this case space, how do we really make a decision and how could technology help us on that? So whenever a clinician is making a decision, he goes by the clinical findings, looks at laboratory investigations, and then tries to amalgamate based upon the clinical evidence. And in the mind, everybody of us will have an algorithm which is there to reach a particular recommendation. The problem here is that the knowledge is expanding very rapidly. Every year, thousands of research papers come in, and how do we really be synced up with the latest algorithms or latest guidelines? And therefore, the cases may be missed or missed, and that can have huge implications because pediatric endocrinology does not give you time. If you have a child who is short, he would grow only till a particular age. If a child has hypoglycemia, if you don't manage, there will be difficulties. If DKA is not managed appropriately, you have limited time, otherwise complications will take up. So immediate clinical decision making is absolutely essential, and that often has to be done at the level of non-experts who are not dealing with pediatric endocrinology day in and out. And this is coupled by decreased amount of exposure to pediatric endocrinology, making the whole thought process quite challenging from that regards. So over the last 15 years or so, we started off first with workshops. We have conducted over 150 workshops across the country. We have conducted a number of practical pediatric endocrinology courses. But what we realized is that there is a limitation of how much you can do, and the retention time after these courses is less. So we tried to use the social media. We tried to start our on-site fellowship, but again, you can have only 2 fellows a year. So how quickly you can spread out. And that brought the Medi classes, which was set up in 2018. And over the last 7 years, we have had over 1,500 people who have trained across the globe, including 120 of people who are doing or who have completed our fellowship program, and publications which come up in that regards. So coming back to the original 3 A's of pediatric endocrinology, what could help out in a country which has got less resources, and we have limited number of manpower also as far as pediatric endocrinology is concerned. And then we thought that technology could be the solution, and I'm going to showcase how technology has helped us and has a great potential in the future in terms of pediatric endocrinology. So in terms of problem and solution could pretty much be technology in that regards. So as clinicians, our major role is to diagnose a particular disease, to interpret a particular analysis, manage a case, and often have to decide on an urgent basis where we are not aware about what will be the most appropriate strategy. And I'll try to see how technology can help out in that regards. Technology is also helping in specific scenarios like continuous glucose monitoring system, like the development of insulin pump, but these are more in the domain of the practicing pediatric endocrinologist. So I have not touched based upon that. I've tried to do the technology that we have developed and the technologies which are available, which can help ground level changes in terms of assessment and management, because first contact is the most important aspect as far as pediatric endocrinology is concerned. So diagnosis in the most common case that pediatricians see is that of growth failure. We have a 12-year-old girl who presents with short stature, height is 120 and weight in 15. Now the big question is, we know that short stature is common. Most of these cases are physiological, and a reasonable proportion of them also have a pathology. So the role of a pediatrician while assessing a child with short stature is not to do too many workup in these physiological cases while not missing these pathological ones. So this is a balance that they need to strike. This, of course, can be done if we have enough understanding of the process. We know that growth failure could be physiological or pathological. And if we do proper evaluation, we can classify whether this child is short or not, whether this is pathological, as highlighted by height, which is less than the general population, the family, and the bone age. Then it's primary or secondary based upon the birth weight, the dysmorphism, clinical features, and nutritional or endocrine. And therein lies the assessment of key parameters, including the growth chart, the pubertal status, and bone age. So these all have been emphasized a number of times in terms of clinical practice. And we have developed algorithms also, which provides a resource-poor setting approach. So in our approach, we are using investigations only if there are particular issues in terms of evaluation or management, and we are limiting resources. And this has been proven to be cost effective. However, when we analyzed the recommendations using case scenarios to 250 patients, when we compared the information which is provided to them to the pediatricians and the trainee, we found significant major and moderate discordances which was seen in these cases. So in a number of cases, the pediatrician and the pediatric trainee were missing the pathology. Sometimes they were also overdiagnosing. So again, doing workup when it was not required and not doing workup when it was required was clearly happening, resulting in misclassification. And this was something which was a really cause of concern in that regards. So what we thought would be an appropriate tool to develop is to implement the algorithm, make the algorithm run directly for the clinician. So they would need to then just use the guidance and use their own clinical justice to reach a correct diagnosis. So we developed our MediClasses Endocrinology app, which is the most downloaded endocrinology app across the globe. It has got over 10,000 subscribers and it has got multiple pathways. So we have got approach pathway, wherein the clinician just have to input in terms of question answer forms, in terms of the various parameters to reach a final diagnosis. There are approximately 50 approach pathways which are covering the entirety of pediatric endocrinology. There are management pathways which look into the management of individual conditions, in which the clinician will then again ask and answer question answer form. The algorithms will run in that regards to reach to a final diagnosis. There are interpreters, which are novel intervention in which you need to have just a quick bound solution, because till now people were saying that algorithms may take a time. So what these interpreters do is that basically if you put in the data, they will give you immediate instantaneous guidance in terms of varieties. So there are around 20 interpreters, which I'll try to showcase how they can help in that regards. There are calculators to help assess bone age, which is a major problem, which I'll talk about a bit later, and other clinical parameters to help out on that. So this app essentially is like the pocket pediatric endocrinology that we try to develop. In the sense, we have got guidance coming right in the mobile application, which has been validated to the level of experts. And this is how expert will help you out. And then you can make decision about what investigations are to be done and what are not to be done in that perspective. So this was our first publication on the mobile application for point of care growth evaluation. This involved a large data set of around 900 patients presented to our clinic. And what we found that there was 99% concordance with regards to the output from the mobile app. It provided the right guidance in these majority of cases. So how does it work? So let's go in terms of a clinical example of a 12-year-old girl whose height is 132, weight is 20. And if we plot the chart, and we all know how to plot the chart, we see that this girl is short for the population. But when we correct it for the mid-parental height, which is the average height for both mother and father, subtract by 6.5 for a girl, this girl is not short for the family. So she is short for the population, but not short for the family, implying that this looks like a familial short stature for which we don't need to do much investigation if the bone age is delayed. Now, this is something which will come if we analyze the growth chart properly. If you just feed it into the app, you will get the information that this is clearly the scenario, that this is a familial short stature. You don't need to do workup. So this can clearly guide you out that this child needs workup in terms of the weight, but not from other parameters in that regards. And these are based upon our algorithms. So this is clearly a familial short stature. Another scenario, a 13-year-old boy, and we see this boy is also short for the population. He is also short for the family. What's interesting is that this child is not short for the bone age. So whenever you're looking at a short child, look at three questions. Is he short for the population? If no, no workup. Short for the family? No. This is familiar short stature. The first case, no workup. Not short for the bone age. This is most likely CDGP in that regards, and his height and weight was both compromised. Now, interestingly, in this case scenario, a growth hormone stimulation test had been done earlier by a clinician, and quote unquote, a diagnosis of growth hormone deficiency was made. Now, if you look at this pattern, 99% of boys before puberty who present to you with just below the growth chart do not have growth hormone deficiency. And if we had not done a primed growth hormone testing, we had not given testosterone a week before this test, this could result in an erroneous scenario. So this doesn't look like GHD. So if we had used the growth chart, or we had interpreted this data. So this app basically looks it and provides us with the number of information. It gives us information about the height standard deviation score, the weight standard deviation score, the BMI, the target height, and very importantly, how the bone age is going and how the height is going for bone age, and giving us a diagnosis of likely CDGP. The next generation is also providing us what workup is required, how we need to evaluate. So this is how it could have avoided this unnecessary diagnosis of GHD in that regards, and we would have labeled a CDGP. Another scenario, 10-year-old girl whose height is 120, weight is 15, basic workup is normal, TTG is normal, karyotype is normal. Again, IGF-1 level was done, which was found to be low. Basal growth hormone was low, advised growth hormone deficiency. And if you can see again, this child, this chart is something which we should memorize in our minds. This child is short, but the weight is much more affected than the height. So this is clearly a case of nutritional pattern growth failure. It is extremely unlikely to be growth hormone deficiency. We know that the IGF-1 levels may be low in setting of malnutrition, and basal growth hormone has no role in evaluation. So again, if this chart had been analyzed properly, or if we had used our mobile application or any other tool which provides you this information, you would know that clearly here the BMI SDS is very significantly affected. So this is not growth hormone deficiency. This is a nutritional pattern. So again, we would have saved unnecessary workup in that regards. Remember that TTG may be negative if somebody is IgA deficient. So what we did here was to look at IgA, which was found to be undetectable in this case. So again, growth hormone deficiency was overdiagnosed in this scenario. Another 8-year-old boy with height of 100 centimeters, weight of 18 kgs. And again, the workup showed a normal initial screening and a TTG was slightly elevated. So this child was labeled as celiac disease, but on gluten-free diet, there was no improvement. If we analyze the growth chart clearly, what we are seeing is that the height is much more affected as compared to the weight. So this is clearly a case of endocrine pattern growth failure and not nutritional. And this is unlikely to be celiac disease. And this is most likely growth hormone deficiency. So if we analyze the data properly, which the app is doing right at the background instantaneously, we can immediately make a diagnosis that this is an endocrine pattern and not a nutritional pattern. So what we have tried to do, and which has been found to be quite successful, is to build a decision tree. The same algorithm which has been used in our clinical practice is applied clearly so that there is no error in terms of estimation of all these SDSs and their interpretation. The second big problem that we encountered is obesity. So this is a 16-year-old boy who is 127 kg. Very common problem now, obesity. Again, more likely to be physiological. Only 2% have a pathology. But again, we don't want to miss pathology in that regards. So when we talk about obesity, we know that 98% are physiological, especially if the growth, puberty, and development is normal. This is likely to be physiological. While other disorders will be pointed out, like genetic, if there is hyperphagia, vision abnormality, pubertal abnormality, drugs history we can get, and endocrine causes should be considered only if there is a growth or pubertal delay. So this provides us with an opportunity to develop an algorithm, which we have developed using the osteological criteria, and then looking out with regards to the various parameters to decide about the need for any particular workup from that regards. And this again has been validated in our study in the form of an obesity interpreter, in which all you have to do is to feed data and you will get exact interpretation as to what are the likely diagnosis, how to evaluate, how do you manage, and again, a very high level of concordance, above 99%. So this can be used as a point of care tool by the pediatrician, which will guide them about the need for workup and various regards. Just to showcase a couple of examples, a very common scenario of a child who comes to us with obesity. Child is reasonably tall, and what was found that the TSH level was 7.91. So this child was labeled as hypothyroidism, started on thyroxine, and the clinicians and the parents were happy that this child will improve on thyroid. But what we need to remember is that this TSH elevation is not the cause of obesity, it is the effect of obesity. And what clearly is that this does not require treatment. And if we look at the growth chart pattern, which we are seeing here, this is a case pretty much of constitutional obesity, because what you can see is that the weight is there, but height is also high. The most important thing to look at in a short child is the weight. If the weight is less, this is indicating nutritional. Short and plump is endocrine. The most important thing to look at in an obese child is the height. If they are tall and obese, this is exogenous, constitutional, physiological obesity. And this PSH elevation does not require any treatment from that perspective. Another scenario, 12-year-old girl who is short and obese. Her basic workup was normal, but she presented later on with weight gain. Now, if you look at this growth chart, what you are seeing clearly is that this child is short and plump. And short and plump clearly is a marker of pathological obesity. If you go our chart, what we are using here is to look at the height SDS. And if the height SDS is less than minus 0.5, it indicates that this could be an endocrine pattern and we need to do evaluation. So while only 2% may have pathological causes, if there is abnormal vision, abnormal faces, abnormal growth, puberty or development, think of a pathological cause, do not miss it. At that point of time, that becomes important. And this child turned out to be Cushing syndrome. So this is something which is important to evaluate, assess, and manage from that regards. One of the dreaded scenarios which pediatricians encounter for the first time is disorder of sexual development. And we know that this is not only a social, but a medical emergency. And if we don't make the diagnosis, this could be make and break scenario. And often the first counseling which is done by the pediatricians has profound impact in terms of the parents, particularly with regards to the gender of rearing, evaluation and management. Moreover, since it's not a very common disorder, there can often be confusion in terms of evaluation and management. So this is a clear emergency. We looked up DSD as a challenge. There is, of course, an algorithm, and this looks very complicated, which we look at it. But this is what will provide you a precise diagnosis. This is our algorithm, which we are using. It looks predominantly into clinical parameters. Gonads, yes, no. Mullerian structure, yes, no. Basic classification, and then we do the workup. So the challenge of translating this into the form of an algorithm and then into an interpreter was that we wanted a hierarchical sort of assessment. Based upon your initial inputs, you get the output. So we'll start off with this case. There is bilateral gonads. There is no uterus. So this case is a XY DSD. Testosterone is not undetectable, and there is hyponatremia and hyperkalemia. Now, if you go into that complicated algorithm, you would say, okay, this is XY-DHD with salt wasting with a detectable testosterone. This looks like a 3-beta HSD deficiency. Now, how our app works is that you will sequentially have to input the data, and based upon that, it will give you a diagnosis as to likely diagnosis from that perspective. Another interesting case, day 3-old child, we can see this child has no gonads. So that child had gonads, looks like a XY-DSD, no gonads. This is clearly a XX-DSD and Mullerian structure is present. The first question is gonad is absent, Mullerian structure is present. It's going to then ask us about whether the maternal virilization is there or not, which is not there in this case. It will ask about 17 OHP levels, which of course will be high. And this is a rare, the most common cause of DSD. This is 21-hydroxyl deficiency. It will tell you about the likely diagnosis, treatment, gender of rearing, and further workup. So this is how it goes from very common to more complicated cases from that regards. Another child, very interesting, similar scenario, no gonads, Mullerian structure present. Again, very interesting scenario here was that there was maternal virilization. So now we can really bypass other things. 17 OHP is slightly elevated, labeled as CAH. But if you use our algorithm using the app, it will say the 17 OHP is high, but not high enough for CAH. If you really have some basic parameters, we'll then make a diagnosis. This is aromatase deficiency. So the application provides us with an algorithmic approach across bound to produce a correct diagnosis in that regards. 14-day-old child with DSD, very interesting scenario. You can see on one side there is gonad, the other side there is no gonad, there is asymmetrical genitalia, there is both gonads and uterus. So this is a scenario where gonad is present, Mullerian structure is also present, and there is asymmetrical genitalia. So again, it may be very confusing, but if you put all the data there, the algorithm is there to help us. It will just ask about AMH, and it will tell you that this is a over-testicular DSD. So we have developed this DSD interpreter looking into the entirety of picture. We have validated this again against experts, which are pediatric endocrinologists, neonatologists, pediatricians, and trainee. What we can see that there is significant discordance, which is there particularly at the trainee and the neonatologist level. wherein more than half the cases were incorrectly assessed and managed, and many significant pathologies like CAH, like 11 beta hydroxylase deficiency, like 3 beta were missed, which could have been fatal. So if we use this app, and this is what we're proposing, this could help us immediate classification. Of course, this is not going to be 100% perfect. In this scenario, it was 97% accurate in our cohort, around 100 cases of DSD. But of course, there will be some variation, but we'll give you the guidance in terms of what is required in that regards. Now, AI-based tools have also been developed, and there is one which has been developed by China. Now, what we need to, I just touched base about what AI and what these sort of thing which we call as decision tree, the difference between them is AI, you need a huge number of data. So if you want to develop a AI-based interpreter for DSD, you would need at least 10,000 cases of DSD. You need to have hundreds of information about them, and then you put into the data, it is then going to make a decision. Often for these clinical scenarios, the algorithm-based interpreters do better than like the AI. There is one paper in which the Chinese people have used the AI technology from the data was coming in from around 5,000 patients, and they were able to get a diagnostic accuracy of around 75%, which is much lower than our algorithm-based approach. So it's not that everything AI is going to be superior. AI is good where all the data is available, where everything is available, but for most scenario, that's not possible. And these decision trees are quite good from that regards. So we have developed a number of interpreters to interpret puberty, right from delayed to precocious to peripheral to central, all forms of puberty. For hypoglycemia, neonatal, post-neonatal hypoglycemia, calcium hypocalcemia, hypercalcemia, the single one, you put the data, it will then guide you through both hypercalcemia and electrolytes. So we are pretty much covered in terms of every aspect of pediatric endocrinology in which real-time decision making is required in that regards. So puberty is something which is quite common that pediatricians encounter. We have a 2-year-old girl with thelarchy. Onset 6 months ago, this was slowly progressive. So again, this is the age in which isolated thelarchy can present often, and there was only breast stage 3 development. Height was normal. There was no cafe or spots in that regards. So a puberty interpreter, all you have to do is to basically select the pubertal status and put the height, bone age, and menarche, and rest the app will evaluate. The algorithm which I have presented in the background is used and will tell you whether it is isolated thelarchy or not. 6-year-old girl with thelarchy, again a common presentation. We can see breast stage 3. This girl is tall, and often the gynecologists are saying that you don't need to worry. These days, puberty happens early. But when we really analyze the data, like in this case, bone age is 11 years. If we really put it in our perspective, what we are seeing here is that this child is tall, but she is not tall enough for the bone age, and she will have a definite compromise. So this is clearly a rapidly, so we have algorithms as to when to call it rapidly progressive precocious puberty, and we need to do workup and treatment. So again, it will guide you about evaluation and management from that perspective. 6-year-old girl with pubarchy, again, she had a normal birth weight, has stage 3 pubic hair development, again a cause of concern. This is quite significant. We need workup for CAH. So all the algorithms which may be difficult to follow, we have done full workshops on puberty for 2 hours, and still when we do the post test, it's difficult. When we do the post test after a week, people even have limited attention span. So this is something to carry forward. Once you have read everything, you can use it just for reference to see whether the path is going quickly, and it's going to be quite quick in that perspective. A very interesting clinical scenario, 7-year-old girl with vaginal bleeding, single episode, no breast development, no pubic hair. There is the one vaginal bleeding which is there. So dictum is that if there is no breast, it cannot be hyperestrogenic. It has to be a local cause, which could be a trauma, tumor, abuse, or some infection. Vaginal mucosa was red, again suggesting that this is most likely a scenario wherein we have no estrogen exposure, and clearly this scenario came out to be isolated vaginal bleeding. So again, using these algorithms can really help out reach a diagnosis. The final case as far as girl with precocious puberty is a short girl with precocious puberty. All of you should have this in your background. With or without app, you can make the diagnosis. 7-year-old girl, very short with thelarchy and vaginal bleeding. And we can see that she is very, very short in terms of growth. She has a large ovarian cyst. This is a classical case of von Wijk-Grumbach syndrome, wherein the TSH is acting on the FSH receptor. There is uncontrolled hypothyroidism causing this problem. And if we put these data, of course, on the app, it is also going to help out in terms of reach the diagnosis that this is classically a typical case of hypothyroidism. So again, logic can help out. As far as precocious puberty in boys, we know that the testicular volume is the most important thing. This is a boy with precocious puberty and large testes, which means that this is most likely a central precocious puberty. We need to evaluate what workup needs to be done. We can identify from that perspective, and this turned out to be a hypothalamic hematoma. So I'm just giving you an overview how clinical scenario, if we have the right aptitude, we can make the diagnosis, but there are technological tools which can help out reach the diagnosis. On the contrary, we have a 7-year-old boy with early puberty, and what we see is that the testes are not that large. So this case where testicular volume is not large, this is a peripheral precocious puberty. So again, we know which way the workup is. We don't need to do MRI in this scenario. So the application can help us reach the diagnosis of hypothalamic hematoma, CAH, in a wide variety of cases. Going on to another interesting scenario of hypocalcemia, which is a common presentation to the pediatricians. 4-year-old girl with tetany, ionic calcium is 3.1, phosphorus is high, PTH is high, labeled as PHP. So this is not unusual pseudohypoparathyroidism presentation, but clearly here the mistake was that the creatinine level was not done. So when we look at approach to the algorithm as far as hypocalcemia is concerned, we have to look at phosphorus, which is the most important parameter. If phosphorus is high, most important thing is to rule out renal failure. And if the creatinine is normal, then PTH can help out. So in this case, there was wrong sequence of evaluation which was done, and that could have caused a lot of problems. So again, our calcium interpreter is the next generation one. So it goes according to the parameters. So in this case, what it's asking is what is the creatinine level clearly here. And we know if the creatinine is normal, the next step would be to look at magnesium. And again, the magnesium level is here low. So clearly this is hypomagnesemia. So it will be stepwise in terms of what workup is required from that regards. Again, a 3-month-old girl with seizures and phosphorus is low, calcium is also low, PTH is also low. So this is a very unusual scenario. We know that if the PTH level is low, phosphate level should be high. So if the calcium is low and the phosphorus is low and PTH is also low, there is something wrong which is happening. And most likely this could be an error in terms of clinical interpretation and evaluation. And when a vitamin D levels were done as we go by our algorithm, where you have hypocalcemia with a normal level of creatinine, with a normal level of magnesium, the next step, of course, is to look at the phosphorus level, which will guide you the workup. And here what we are seeing is that phosphorus level is low. And if the phosphorus is low, the next step is not PTH. You should do vitamin D. So if you follow the algorithm, vitamin D will give you the diagnosis. And this low PTH was because of inappropriate transport. So again, a very, very important scenario to identify. Another scenario of a 1-week-old boy with seizures and hypocalcemia, hyperphosphatemia, normal creatinine, and high PTH. This was a case of pseudohypoparathyroidism who presented at a young age and later on was confirmed as pseudohypoparathyroidism with many other scenarios. So we have tried to develop mobile application-based interpreters for a variety of disorders, also for diabetes, wherein classification could be a problem. So you can classify diabetes, decide about whether you need to do investigations or not. And we have shown that we could reduce the need for investigations in a large number of cases, both for diabetes as well as hypoglycemia. So these interpreters are essentially algorithms in action, which provides us with technological help in reaching out to the periphery where you may not have an immediate help available in terms of expertise to get the right diagnosis and get the correct treatment from that regards. Like in this case, we're going towards the hyperinsulinism pathway, and based upon the diazoxide response, we're going for genetic evaluation. Another group is, of course, the electrolyte disorder. So we have got a tool which includes into every parts of electrolyte to reach a final diagnosis. So in a way, these interpreters are there to help out. Now, I've always talked about a number of things. So in terms of the next aspect of force is how to interpret. So we have diagnosed, but how to interpret, and here it becomes a big problem. And one of the major problem in interpretation has been that of bone age. So this was a child who was referred to us with, quote, need for growth hormone therapy because the radiologist had reported the bone age as 14 years. Now, I have seen all sorts of radiology reports with bone age ranging from 5 to 15 years, from 10 to 18 years, to no evidence of fracture and rickets. So I've in fact jokingly told the radiologist friend that probably you should say 0 to 100 years. That will be 100% sensitive and 100% specific. So what was wrong in this case? This child, if he was bone age is 14, he's so short, he needs growth hormone. But when we look at the bone age again by ourselves, we found that the growth hormone was only 10, the bone age was only 10.5 years, and there was no need of treatment. So problem is that we do not have access to reliable bone age, and bone age is a challenge. There are methods which are available, the GP Atlas, in which you compare the full hand to the bone age. There is the Banner Whitehouse, where you have to select 20 sites to reach the right diagnosis, and the Bone Expert, which provides you automated information. Problem is they are time consuming for case 1 and 2, and they're expensive for Bone Expert. So what we tried to develop was a simple and accessible tool, which is validated against gold standard and provides us with good information in terms of bone age. So we tried to minimize the number of sites. So we came down to only 5 sites, which were most important. And when we used those 5 sites, we found that it was very effective in terms of accuracy and precision. So what you have to do is just compare the X-ray with particular findings. So there are 5 different sites which you have to match for. And once you match, you will get the outcome in terms of the bone age, which will be quite quick. Once you match all those sites, it will give you the final bone age diagnosis in that perspective and a range as well. So this method has been used extensively. We have done studies and validated again gold standard, found to be quite effective in terms of variations, in terms of the intra and inter-individual variability, and procedure time significantly decreases by around 70% for expert users, and as compared to non-expert, again, the time is much less. So this can provide you a much quicker turnaround time, very accurate for our pediatric trainees as well. So DNB trainees also had a good amount of accuracy. So we have now a tool which has now been there for the last 6 years, which has been used extensively, right point of care, immediate evaluation of bone age. The next way to go ahead in terms of bone age evaluation is AI-based tools. And here AI can really help because we have got large data sets which are there for bone age, like 10,000 data set, which has come from the Radiology Society of North America. Based upon that, AI-based tools are coming, and we are also developing one with IIT Kanpur, hopefully, which will provide us with precision of approximately 6 months. So all you have to do is to look at the image. It will immediately give you the bone age and give you the right diagnosis in that perspective. Image-based assessment and where AI comes in. So I talked about the role of these algorithms, which are basically decision trees, but AI is also helpful when we have a large amount of data. So we all are very well aware that we have about phase 2 syndrome, the one in which you can just have to put the picture and it will tell you the likely diagnosis of particular diagnosis. So this is something which is quite relevant in terms of diagnosis and something which is going to come up quite soon. Another scenario, a 12-year-old girl with lethargy, she was found to have a low FT4 and a slightly elevated TSH. So based upon this, a diagnosis of primary hypothyroidism was made, and the physician started thyroxine, resulting in hemodynamic instability. Now we know that if you have a low FT4, the TSH should be sky high. Marginally elevated TSH in this setting would suggest a central hypothyroidism, the need for MRI and need for adrenal evaluation before you start treatment. So clearly this was one scenario where it was wrong in terms of interpretation. So a TSH which is below 20 and FT4 is low, think of central hypothyroidism. And thyroid function is by far the most commonly prescribed test, endocrine test by any pediatrician. So what we have done is that we have developed a thyroid interpreter, which based upon the age, whether it's neonatal period, children, non-pregnant or pregnant adults, you just enter the FT4 and TSH, and it will give you the most likely diagnosis in terms of what are we looking at in that perspective. So again, if you go back to this case, have we had done this evaluation, put this data of FT4 and TSH, FT4 which is low, it will say consider central hypothyroidism. So all the confusions in terms of the units which are used, the assays which are used, we have incorporated that to give you a clear single guidance which you can then correlate clinically to make a decision in terms of that. Another challenge which we found was late diagnosis of thyroid nodule and not doing FNAC where required. So clearly this is a girl who has got a single nodule. As against goiter, if you see any child who has a solitary nodule, there is a very, very high chance of malignancy, around 10%. So this needs immediate evaluation. However, this girl was reassured. We have developed a thyroid nodule interpreter, both for pediatric and adults, based upon the size and ultrasound finding. If you just put that it will tell you whether you need a FNAC, and based upon FNAC, what you need to do. So this is again a decision tree which is there. So we have a number of thyroid tools for congenital, acquired thyrotoxicosis and nodule which are there. Now, we are also trying to bridge everything up. We know that for a pediatric endocrine assessment, you need to assess growth, puberty, obesity, and bone age. So what we are trying to bring up is BIG, which is bone age assisted interpretation of growth, which will be a significant technological advance. It will be like an EMR system. You just put in all the data, select the pubertal status, select the bone age. You will get a growth chart, likely diagnosis, pubertal staging, pubertal interpretation, growth interpretation. So all our algorithms are coming together to give you a final diagnosis out there. And this is shown to significantly improve the discordances which are seen for pediatricians and pediatric trainee. So this can, in a way, improve the quality of assessment which is happening at the level of primary healthcare in terms of that. After you have diagnosed, after you have interpreted the test, you of course need to manage these scenarios, and this can also be a challenge. And one of these scenario is DKA, which is the most common emergency managed by a pediatrician as far as endocrinology is concerned. So a 4-year-old girl with DKA received fluid and insulin outside, presented to the treating team with hypokalemia, was given normal saline followed by insulin, suddenly developed arrhythmia. So now we know that this is because the potassium was low. You start insulin, potassium is pushed into the cells, the hypokalemia will happen. And this, unfortunately, is not uncommon. People talk about India as a low incidence country as far as type 1 diabetes is concerned. But I, from my experience, looking at the late presentation of most cases of severe DKA, know that this is not true. Many of our cases are not picked up at the right time and are not managed. This is what is happening at tier 1, tier 2 cities. What is going to happen in tier 3 cities, in villages? How many of them will be managed or not? What we did, we know the DKA, the protocol is there that you give fluid, and along with that, you give insulin and potassium, everybody, which becomes important. There are protocols there, there are algorithms there, but the problem is that they are not being followed appropriately. We need to know that we don't want to give too much fluid because giving too much fluid can cause cerebral edema. We don't want to give too much insulin because that again can cause hypokalemia. All these parameters are there, but when we evaluated our own ICU analysis, when we looked at the case records, what we found that there was a significant number of errors which were happening in management, and most of the errors were happening in the initial one. So the pediatric trainee, the first person of contact should be the most strong when you're managing any chronic, any acute condition, because that's the golden hour. And these errors resulted in, once we corrected it also later on, resulted in hypoglycemia, hypokalemia, and dehydration. So what we did, we used the ISPAT algorithm, which looks very complicated. Often the problems were too little fluid was given, too much fluid was given, insulin dose was incorrect. Now all they have to do is to just put these data. So all our ICU patients are being managed using the interpreter. It will tell you how much fluid is to be given, when to insulin to start, and how do we adjust based upon your follow-up GCS and other parameters, whether it's time to switch over to other parameters, how do we evaluate and manage from that perspective. So this DK interpreter has been published and has been found to be effective. Another scenario which type 1 diabetes, of course, is a big challenge is of people education level. And most of our patients are having resource crunches. They are in remote areas. This child was being given free insulin, but suddenly developed sick day and DKA. And all the costs that are saved by giving insulin is spent in one single admission. So if you're able to prevent one case of DKA, you are not only preventing a life-threatening condition, you're also providing them a lot of cost, which can be used for many years in terms of insulin treatment. And that is something we wanted to do. So we've developed tools for physicians to decide about the bolus dose of insulin, about the correction dose, and the basal dose from that perspective, and manage sick day. What we are also now aware that there are AI-based systems which are trying to develop technologies to predict what will be the right dose as far as AI is concerned, based upon the glucose reading, insulin, meal, and activity. And we are going to club all of that in a forthcoming app, which we are now analyzing and assessing, the Diabetes app, which will guide about insulin dose, track the glucose, activity, sleep, eat, and sick day to provide guidelines with regards to what will be the correct dose, especially during sick day. This is going to help out in that regard. So having talked about diagnosis, interpretation, and management, once in a while we are coming up with a challenging scenario where immediate clinical decision is important and we may not have expertise available, especially if somebody is in a periphery. So we have a 16-year-old girl with weakness and lethargy, there is vomiting and pigmentation, there is hypotension, hyponatremia, hyperkalemia. Now, anybody who has a good knowledge of pediatric endocrinology or pediatrics will say this looks like adrenal insufficiency, consider starting steroids, do these investigations, but this may not be easy for somebody who is just a recently passed out pediatrician who is working out in a remote area. So how do they get the knowledge and how do we assess, evaluate in these cases? Of course, they can go back to the textbooks, but textbooks are so voluminous, they don't have time to do that at the right moment. They can use e-resources which are available. We have developed our learning portal which provides this knowledge. But the best opportunity now probably is coming out from large language models. And the classical example of that would be something like ChatGPT. We understand the importance of knowledge and we know that the development of app has limited role unless the knowledge is there, and therefore we have developed 3 books. One is that of protocols, then basic and advanced, covering the entirety of pediatric endocrinology. But this again is not easy to follow up because this will be like 1500 pages, so you can't go back directly. We have e-learning portal in which we have developed a number of videos for developing these resources which can be referred to. Again, this is something not easy to do. And as I discussed, we have developed a learning course for a full 2-year period. But how can somebody use these tools if they don't have limited time to access? So this has been a very interesting study which has been recently published in JAMA, which looked into the output from large language model, quote unquote chat GPT, without various clinical parameters. And they found that there was largely accurate guidance which were coming in. And one good example here is the Glass AI, in which if I've just put in the data which has been provided here, you just put the data there, it will start analyzing as to what is the most likely diagnosis, the differential diagnosis, assessment. So in a way, we are now coming into a combination of all our algorithms and landing up on that perspective. So this is the way forward in terms of learning, where AI, decision trees, and technology can help us reach a diagnosis, make assessment in that regard. A lot of people, often when you talk about technology and AI, they talk about technology being a threat, that it can take off our jobs and we can have doctors which are basically robots which can work on that. Importantly, in various fields across developed countries, 77% uptake is there, and it's expected that a large number of jobs with and without healthcare would be affected. But what we need to understand is that we need to have doctor in the loop. Without the physician in the loop, it's impossible. So human becomes absolutely important, and we need to understand that as times progressed, earlier people talked about computers, how they can change, how mobile they can take over. It's that they can be helping us out. So if we use them as an assistant, it can be a very, very effective tool, especially under regulation. So technology is not something we need to be wary about. We need to work and partner onto technology in that regards. At the end, I'd like to thank all the students and fellows who have been working with us, who have been awarded the various awards, including Dr. Riddhi. This was in Kolkata in 2019 about our bone age tool. Dr. Sayan, again, West Bengal IAP Award for Puberty Interpreter. APES awards with regards to DSD interpreter, Dr. Dhwani received this award. Then a big was presented in SP as well. And then number of presentation on a bone age and publications which are there on these tools. We are working on another 6 publications which are on the track. So this hopefully will provide enough evidence for point of care evaluation, assessment, and management. At the end, I'd like to thank the entire team, my gurus, Professor P.S.N. Menon and Professor George Verda, the tech team, Shalabji and Prabhaji, the team CDR. We till now have around 13 fellows which are there, and Dr. Nishit, who is from IIT Kanpur, whom we are collaborating on many of our AI projects as well. And again, thanks a lot to Dr. Sumana, Dr. Atanu, and everybody for patient hearing and providing me with this opportunity. This talk was more of giving the glimpse as to how this can happen. And this is, I've talked about pediatric endocrinology, but I'm sure this can be developed across every specialty in pediatrics, every specialty in medicine, and then it can make life easier. The point is that we should not be afraid of technology. We should be using technology in a positive fashion and use it. If we don't use technology, technology will definitely replace us from that perspective. Again, thanks everybody for patient hearing.
Thank you so much, sir. That was such an enlightening talk as usual. And I'm just thinking that what an amazing work that you've done in utilizing technology and creating these apps, interpreters. And I'm sure the future looks very bright. And we are all grateful to you. The patients will be grateful to you because this will actually bridge the gap, and the patient care, the pediatricians will feel empowered. Once they use it, they know it, how beautiful these interpreters are, because I've used it myself, I know. And I think there is one burning question that everybody, I think, would love to ask. Can this app be downloaded from Play Store, sir? Will you just tell?
Yes. So this is available on both Android and iOS store. It can be easily accessed from there. It's in fact one of the most downloaded endocrinology application on the Android store and the iOS store. So, and a lot of positive feedback has come from there. Thank you.
Yes, sir. So you have to use it to know how beautiful these are. Any more questions? I can't see any more questions in the chat box. Shapun sir, can you see anything else?
So, technical teams, please put the questions in the chat box from the audience. This is the faculty link. In the audience, there may be some questions.
Yes,
If you have,
Let us
please
check,
post
sir.
it.
Yeah, let
Yeah.
us check, sir.
So it was a wonderful talk, and we are really mesmerized. So I will take from Sumana your 3 books because I want to read.
Sir, it will be incomplete if we do not thank Dr. Anurag Bajpai in such a simplified way. He has explained everything, sir. Congratulations, sir. Wonderful talk.
Thanks.
We enjoyed.
Somebody's
just
writing, please
announce.
post the link. Is there a link to the app? Then
Yeah, app
Okay.
links they might be asking app link. Yes.
So can you please
Yeah,
give-
I'll do that. I've done that.
Yes,
So they
all
can
right.
go to
Yeah,
that.
it's there already, I think. Thank you, sir. Anything else?
Sumana, you can take that link and the name of the app and you can post it. So I will be giving to all the delegates who have joined.
Absolutely, that would be really useful. I'll do that, sir. I'll do that. Okay, then. So I would request, yes,
Yes.
Atanu sir
So-
or Mihir to give the vote.
Otonu, please unmute. Otonu, please unmute. I think he must be busy with any other meeting. Anyway, so I'll request each and everyone, because we have already unmuted you, to make your comment about today's session. So over to you, Amal.
I think there is no more question from the audience. It was such an enlightening talk that people are mesmerized, I think. Okay, we'll post the link, of course, for everybody's convenience. And over to you, sir.
So if anybody wants to comment, everybody has been unmuted, so you can give your comments. Amal? Champakda? Shomirda?
Hello,
Yes.
am I audible?
Yes.
Yeah.
So I don't know what to say. I'm mesmerized in such a way that I'm not mesmerized. I'm hypnotized, rather. So I cannot say anything. But the one thing actually I'm afraid of that like the people now who are using calculators, they are forgetting multiplication, division. They always go straight to the computer or calculator to get the result. So I don't know what will happen if this sort of apps we begin to try. I don't know. Dr. Bajpai had already said that technology should be used. Nothing to be afraid of. But I am very much afraid of because of the addiction of the apps. I don't know whether they will be going to the textbook. The basic textbook is needed first, and then the apps to be used.
Yes. I think that's a very, very important point, sir. So we need to have a basic knowledge. The apps are basically for people who already have the knowledge, but on the right moment, they need to make the right decision. So often you've learned everything, you forget. Suppose you know that, okay, if you have time, you can calculate 5642 into 4264. You have the knowledge, but you don't have that much time to do it immediately. And if you don't do it immediately, you give somebody gives the wrong dose of insulin, somebody does the wrong investigation, that can have a problem. So this is to supplement. This is definitely not there to replace. And what we have done there is that we have got a full knowledge bank in the app also. So whenever you're looking at precocious puberty, you can go directly and read precocious puberty there also. So there are links there, videos there. So all of them is there also. This is basically a different approach. So my problem when I was a pediatric trainee was that if I have hypoglycemia, I have read hypoglycemia, but again I have to go back. I start reading from pathophysiology, etiology. By the time I come to management, it becomes boring, and books don't give us a final solution. So it goes from the other way around. Okay, you check it ketones first. Ketones are positive or negative, what happens there? It gives a reasonable information right in the beginning. So it's there to supplement, definitely not meant to replace. And it's that by using calculator, we can be faster. Similarly, by using these apps, you could be accurate. Like if you calculate SDS, for every patient, it's going to take a long time. And there are some tools which give you height SDS, they will not give you all the information. So this gives you information, interprets and tells you likely diagnosis. Final decision is by the physician, and we entirely agree with her on that. So human in loop is absolutely important for any healthcare intervention.
Thank you so much.
I think Dr. Amol is there.
Atanu,
no,
please conduct.
It was a very
As you have
mesmerizing
said
talk,
that
as
everybody
already
should be
others have
given
told.
chance. Yeah, please.
Yeah, it was a very great talk, and it was very much needed. And as already Samir Das sir has questioned, but Anurag sir told that it should be a theory first and then practical. Actually, this is very useful app, and so if everybody is using, then it will help in to all the practicing pediatricians. Thank you.
Dr. Devendra Sarina or EB.
Yeah, he already talked. Yes.
Okay.
He can again come in. Yes.
Yes, sir. It was a great talk, sir. I already commented. I wonderfully explained each and everything stepwise, very systematic way. And it was he simplified these all complicated things in a very simple way, sir. And it was a very good algorithm also, sir, to establish the diagnosis, very simple ways. Thank you, sir. Thank you. And congratulations, Anurag Bajpai, sir, once again.
Thank you, sir. Thank you.
Atanu, you want anybody to speak anything? Atanu?
No, I think there are no questions on the chat box also. Let us not unveil everything. Keep something from Pedicon. Let some questions be unanswered today.
Sir, on behalf of the West Bengal Academy of Pediatrics, we are really indebted to you because you have devoted so much of the time for us and our faculty link, those who have joined by the faculty link as well as the audience links. They have benefited a lot, and hope we will get you for such a session in future also. And thank you, sir. Namaskar.
Thank you.
Thank you, sir. Thank you for joining. Thank you so much.
So here we conclude our day.
Sure. Thank
Good
you.
night, everyone.
Thank you. Thank you, everyone.
Thank you. Thank you, everyone. Thank you,
Thank
sir.
Thank you.
Thank
Bye.
you, sir. Thank you. Thank you.